Can you hear me, Dr. Sami?
Yes, perfect.
Yes, it's okay. Go ahead.
Yeah. Thank you, Dr. Sami, for giving an opportunity to speak in this second conference. My talk is not on the surgical techniques which we have been listening for the past 4-5 lectures. It's on decision making to operate or not. And all these years, if you look at the history of prolactinoma patients, surgery was the mainstay of treatment to start with before 1980s. But with the discovery of dopamine in 1980, similar to Parkinson's disease, medical management, the prolactinomas has been preferred to be managed medically. But then there are a lot of myths and facts, like a young female comes with prolactinoma. Earlier, people used to prefer that medical management was preferred, as surgery was thought that it is detrimental to pituitary gland and surgery might damage the pituitary gland and the female cannot have fertility. But then with the techniques of using microscope and endoscope on pituitary, whether surgery is the first line of management or surgery should be the second line in prolactinomas. This is a meta-analysis which was published in this year, where they have did a systematic analysis of all the publication to decide whether medical management or a dopamine agonist should be the first choice in the era of endoscopy, or surgery has still a role in this era. There are many papers on medical versus surgical management of prolactinoma. In this presentation, I'll be taking cases from our hospital and tell when we have opted for surgery and when you opted for medical management in suspected cases of prolactinoma. People also have, this was published in a year ago, where they have evaluated whether surgery should be the first line of treatment for prolactinoma instead of giving medical management, especially with endoscope and microscope being used for pituitary, the results are as better or many times better than medical management. And in this, in the few slides, I'll be highlighting that what is the advantage of surgery over medical management in prolactinoma. Though our protocol till now has been medical management as the first line of treatment, like this patient, a 19-year-old male who came with huge tumor, and this was the CT scan with contrast. As you can see here, this is a predominantly cellular paracellular tumor with intracranial multi-compartment extension. And this was the MRI brain, which shows that there's a cellular tumor with paracellular extension with engulfing of the carotid on the left side. And he had hemianopia on one side. And when we did the hormone level, he had a prolactin levels of 39,000. And we treated with 1 milligram cabergoline per week for 1 month. It reduced to 3,700. By 90% it reduced. And at the end of 4 months, it reduced to 890. And not only the serum prolactin reduced, but the visual also improved. The vision also improved. And look at this, the size of the tumor. This is the pre-treatment, and this is the post-treatment. And it has a significant reduction in the size of tumor. Though we prefer medical management in most of the cases, but still when we analyze of the cases which had 452 cases of pituitary operated in our hospital, we had 62 cases of prolactinoma. Not all of them had a high serum prolactin before surgery, but some of them were taken as prolactinoma because histopathologically they were prolactin positive. Now, why we have such a high incidence of surgery in prolactinoma? Because we had a lot of issues in medical management. The issues are, the cost of treatment, though it looks on upfront that the cost of medical treatment is cheap, but when one compares over 10 years treatment, then the cost of surgery becomes cheaper than medical management. In addition, there are a lot of patients who do not respond to dopamine agonist, at least 10% do not respond to dopamine agonist, then another 10% do not tolerate the drugs. Dopamine agonists also have side effects, and they do not tolerate. Then they had to undergo surgery. And we have a special sequence with young females, especially people who are planning pregnancy or a pregnant lady with tumor. What has to be the treatment choice, whether to give medical management or surgery? So I'll be telling in this presentation what is the protocol for people with having tumors with pregnancy, and people planning pregnancy or pregnancy, what they should prefer, medical or surgical management, and what is the recurrence rate with medical and surgical management. One looks at cost effectiveness. One logically thinks that medical treatment is cheaper, but then this is a paper in 2017, and they analyzed the cost of treatment of medical management, where one has to do multiple hormone analysis, multiple MRI, multiple visits to the doctor, and the cost. And when they compared for a person who has to take the treatment for 10 years, it works out that the surgical cost, the lifetime surgery cost, is cheaper than going for prolactin or cabergoline. Bromocriptine probably is similar cost to surgery, but one uses cabergoline, it is almost twice the cost of surgery. So surgery is cost effective even if one thinks as a first line treatment in prolactinoma. Now this is again another paper where they also concluded that in microprolactinoma, endoscopic or microsurgical resection will be more cost effective than lifelong medical treatment, especially if they have a life expectancy which is more than 10 years. Let us look at the recurrence rate, in whether recurrence rate is more in medical or surgical. Now there are many papers on prolactinoma. These are meta-analyses taken from many published series which has at least 10 patients. The surgical remission rate varies from 40 to 100% for microadenomas and 6 to 80% in macroadenomas. As compared to medical management, in medical management, the dopamine requirement was almost 64% who undergo medical therapy versus 32% who underwent surgical therapy at follow-up. So if one looks at the control of prolactin, surgery, prolactin is probably better than the medical management. Even the biochemical cure rate, if one looks over a period of time, surgery, as you can see here in this graph, this was published this year, that surgery has a better biochemical cure rate than the medical management. Similarly, the recurrence rate, the recurrence rate is analyzed by increase in prolactin and the need for dopamine agonist. Again, surgery wins over the medical management in management. Surgery is better than medical management. Now the surgical, but one has to keep in mind that the surgical outcome is dependent upon not only in the expertise, but also on the size of tumor. Now this paper came in last year. This is the patients who have, patients who have NOS grade 0, they are a good candidate for surgery. But if it's more than one, probably surgery cannot be recommended. Medical management is recommended. So the decision to operate or not depends on the MRI finding as well as the experience of the surgeon. This is again another paper where they did a meta-analysis of if surgery was a viable alternative for first-line treatment, and in the indications I will conclude that where surgery should be preferred over medical management. Now let us look at the dopamine resistance. As I was explaining, 10 to 20% of prolactinoma patients do not respond to the medical management because they are resistant. Now, how do you define resistance? If the prolactin level do not reduce to normal level, or the size of the tumor do not reduce by 50% of the size by 3 months, then they are taken as resistance, prolactin resistance. Like this patient whom we treated with prolactin, with cabergoline, the size did not change over 3 months. This is again another patient, 3 months, small tumors, 3 months, the size did not change, the prolactin level reduced to normal level, but the size did not change. So 10 to 20% of the prolactinoma patient have dopamine resistant, either the prolactin level does not come down or the tumor size does not come down, and hence the visual recovery doesn't happen. And these are again the candidates for surgery. So when do you define a dopamine resistance? When we give 2 milligram of cabergoline per week for 3 months or 15 milligram of bromocriptine per day for 3 months. In spite of giving this high dose, if you do not normalize the prolactin, or if there is no 50% reduction of tumor, or if the normal menstrual cycles are not established, then one has to consider that it's a dopamine resistant, and one has to suggest surgery in prolactinoma patients. Similarly, cystic prolactinomas are bad candidates for medical management because they do not respond to treatment, and they have the vision also doesn't recover. Like this case where we had to do a surgery. Cystic tumors with apoplexy, like this patient, you can see here the fluid level, cystic tumor with the fluid level, again, and with the high prolactin, again, they do not respond to medical management. They are candidates for surgery. So one should upfront explain them surgery as the first line of treatment. There are many patients who develop dopamine agonist intolerance. The common side effect of bromocriptine and cabergoline is nausea, postural hypotension, mental fogginess, and valvular heart disease. And less common is nasal stuffiness and depression, Raynaud phenomena. And this incidence is not uncommon. The incidence of side effect is almost 22% in cabergoline and 43% in bromocriptine. That is almost every alternate patient will have side effect. But then, only half of them or 1/3 of them stop the medicine because they do not tolerate. So 10% of prolactinoma patients do not take the medicine because of intolerance. 10% is approximately they are resistant. So these are again candidates for surgery. Though I explained the complications of side effect dopamine agonist, let me tell that compare the complications of transmural surgery, whether the complication of surgery is higher than the dopamine agonist. And in this meta-analysis, they have analyzed that the complication in transmural surgery, the incidence is far lower than the side effect or complication of using dopamine agonist. Hence, as a complication rate also, the surgery wins over the medical management. Now coming the last indication of CSF leak. Now, if this patient who came with a tumor in the destruction of the clivus, an MRI scan before treatment, we gave medical management. The tumor size significantly reduced, but the patient came back with CSF leak. And when we stopped bromocriptine, CSF leak stopped. So this is another indication that if the patient comes with a high prolactin level, but the clivus is destroyed or the cella is destroyed, then their indication for surgery, because as soon as the tumor sinks, then you have a CSF leak. Hence, these are the patients should be first upfront be suggested surgery rather than medical management. And what do you do when somebody has a pregnancy or fertility? Whether you do medical or surgical. Whether fertility is better following medical management or surgery. Earlier, as endocrinologists, they feel that medical management is better for fertility, but there are many papers which are published where they were analyzed and concluded that fertility actually is better with transmural surgery than medical management. Transmural, this is another paper again where they emphasize the surgery appeared to improve fertility in women with prolactinomas rather than medical management. Because medical management, because the side effects of medical management on the fetus are not known, and we will tend to stop the dopamine agonist after the patient is detected the first week, as soon as the patient is detected to be pregnant. But one of the problem of stopping dopamine agonist once the patient is detected pregnancy is that there can be enlargement of the tumor in pregnancy, especially 5% of the patients in micro and 35% of the macro prolactinoma patients can increase in size, which can jeopardize the visual disturbance. Hence, it's probably recommended that young women who are planning pregnancy, probably surgery is a better option than managing them with medical management. So this is an algorithm which tells us that if somebody is planning pregnancy, what is a better way? And probably, if I want to explain you properly, surgery probably is better than medical management if for young females who are planning fertility or pregnancy. In conclusion, the surgical indication for prolactinomas differ in micro and the macro. In micro, if there is resistance to dopamine agonist therapy or intolerance to medical management, and patients who do not prefer to take lifelong therapy, they should be operated. And if it's a macroadenoma, patients who have cystic prolactinoma or apoplexy, or they have resistance to drug, or the tumor does not reduce by 50% with 3-month treatment, and if there is extensive erosion or destruction of the sphenoid sinus and clivus, because that can lead to CSF leak, and females desiring pregnancy, though, and they are the candidates that they should be suggested surgery. This is what our experience we published in Neurology India 2 years ago. Thank you for your attention.